there is some data which I must share here. In the Trivandrum, Kerala, India program, the 50%, 55% patients hospitalized with heart failure had diabetes mellitus. And today, globally, 30% of chronic heart failure patients have diabetes. And out of diabetics, 10 to 30% patients would suffer with heart failure. So this is emerging as a very important area where diabetic patients should be given therapies which can prevent future heart failure in them. So 20% reduction in CV death, 20% reduction in heart failure hospitalization in this diabetic population, and better glycemic controls, lesser requirement for insulin in this population or oral anti-glycemic drugs. And that is how the benefits of ARNI go much beyond a simple heart failure control. Coming to HFpEF, HFrEF starts at the heart, then goes to elsewhere in the system, whereas HFpEF starts in the oral system elsewhere and everywhere and ends at the heart, presenting as dyspnea. So this is a typical phenotype of HFpEF, where a patient is classically obese, has a lot of visceral fat, there are renal dysfunctions, there are liver, NSHD in the fatty liver. In pulmonary, they have an obstructive sleep apnea or pulmonary hypertension. And of course, in heart, they have large left atrial volume, reduced compliance, and all those parameters on echo. And this all constitutes a typical phenotype of HFpEF. And that is how it manifests as metabolic stress, aging, cardiac remodeling, ventricular vascular stiffening, sedentary lifestyle, loss of cardiac vascular skeletal muscle reserve, and eventually HFpEF. So, and HFpEF population is much bigger than HFrEF because majority of them go undetected in our clinical practice. So the previous trials, which were tried on various drugs like SHARM, iPreserve, PAP, TopCat on MRAs, have all miserably failed. Only evidence which has come in off late was with SGLT2 inhibitor, empagliflozin earlier and now dapagliflozin. And the observational data has also not favored any particular agent in particular for the benefit in mortality or symptoms in HFpEF. So Paramount trial was a trial of ARNI on HFpEF population diagnosed with raised anti-proBNP and echocardiographic parameters of increased left atrial size and of course symptom class. And it was seen here that across the board, all three of them were showing improvement in ARNI, though they were not able to reach the level of significance in terms of p-value for some reason because of the less number of patients recruited in this trial. And this trial was trying ARNI against the valsartan 160 milligram twice a day in this population of HFpEF whose ejection fraction was more than 45%. And what was seen as the primary endpoint, the composite total and recurrent heart failure obstruction CV death, that it failed to reach the significance points in terms of the p-value. But there was a definite trend of reduction in heart failure in HFpEF population with the use of ARNI in the Paragon HF trial. And the way is still open, and we are waiting for some more data in future on the HFpEF and the effects of ARNI in this population. But what was evident that irrespective of the sex and the ejection fraction of patients, the cutoff was emerging as 57%, beyond which the effect of ARNI was lost in HFpEF population, but below which between 40% or 45% to 57%, there were clearly reduction in the heart failure observations and improvement in symptoms of dyspnea in this population. So EF cutoff benefit was 57%, and this was evident that ARNI favors even in the HFpEF population besides the HFrEF data, which I have shown you remarkably well.